Hey guys, so for my clinical pattern project, I had lumbar muscle strain. I am sure by this point in our careers that we all know what a muscle strain is, but just in case you don't, for this area, it's going to be where the muscles in the low back are taken and stretched past their normal length or torn, and you're going to get pain and inflammation with that. For the prevalence of this, you're going to have 80% of all people experiencing low back pain throughout their life, and 60% of those people are going to be diagnosed or self-diagnosed with a lumbar muscle strain. For the population most affected, women are going to be affected more than men, and your middle-aged adults are probably going to be the people that you see the most with this condition, with the exception of your younger athletes. For outcome measures, we have the Oswestry Disability Index, which we learned about today. It's also known as the Oswestry Low Back Pain Disability Questionnaire. And then the Visual Analog Scale has also been used. It's often caused by a one-time injury to the area, and normally it has something to do with lifting something heavy. Aggravating factors are going to be bending, twisting, and then lifting. And then easing factors are going to be ice, rest, and return to functional activity. So with rest, there is a caveat. You only want to rest for the first 24 to 48 hours. You're going to want to get back moving, because the detrimental effects on the muscle strength that you're going to have by resting for too long are going to outweigh the positive effects that you would get from the rest. The 24-hour pattern is better in the morning after you've rested all night long, and then you're probably going to get some aggravation throughout the day just from normal everyday activities. Most patients are probably going to be taken through a review of systems just due to the location of the lumbar spine, but a whole neuroscreen really isn't necessary unless you do have radicular or radiating referred pain into the lower extremities. And in that case, you're going to want to take them through a whole neuroscreen with dermatome, myotome, and reflex testing included. For precautions and contraindications, we're going to want to avoid bed rest, like I mentioned before, and then avoid pain-provocative activities. And you might even defer your resisted testing if your active range of motion is too painful. On that note, with active range of motion, it really depends on where the strain is, like what's going to be painful. You could have extension, flexion, side bending, rotation. Any of that could be painful. And then when you add your passive overpressures, you're going to expect pain in the opposite direction of your active movements. For observation, before you started your active or passive movement, you would observe gait and posture. They're probably going to have antalgic gait, just trying to get comfortable walking and sitting. And a lot of times you see these patients slumped over and just trying to get some relief in that low back. For resisted testing, you're really only going to look at trunk activation, so you're going to have that staggered stance method and just push on them a little bit, see if they can activate those trunk muscles, and then you're not really going to test neurodynamics. Again, you would if you had referred pain into the lower extremities. Special tests are going to be used to rule in and out other contributing factors. So I listed straight leg raise, 90-90, Thomas, and Eli's test for those. For differential diagnosis, it's really going to depend on your signs and symptoms, but you have spondylosis, disc herniation, a compression fracture, spinal stenosis, SIJ dysfunction, spondylolisthesis, ankylosing spondylitis, and I'm sure there are some others. For diagnostic imaging, that's rarely going to be used with this unless you suspect a spinal fracture or a herniated disc. In that case, you can get the physician to order a radiograph or an MRI. Also, you're going to want to get some of these tests done with patients that have a history of trauma or malignancy. And then signs and symptoms indicating referral will be any of your constitutional symptoms: constant severe pain, persistent radicular pain, neurologic weakness, saddle anesthesia, decreased deep tendon reflex, and then pain that doesn't change with position or conservative timely treatment.